Good afternoon, and thank you for joining our second MIRA Idea Exchange. My name is Jazine Alders, and I'm covering the research coordinator position at MIRA while Audrey Patox is on maternity leave. The McMaster Institute for Research on Aging, or MIRA, facilitates connections between McMaster researchers across all 6 faculties with the intent to drive interdisciplinary research. Since MIRA launched in 2016, we've hosted multiple in-person events and exercises to facilitate these interdisciplinary connections. During the summer, when it was clear that the way we had worked in the past would no longer be relevant, we facilitated our first idea exchange. The idea behind these brainstorming sessions is simple. We want to include you, our researchers, directly in the conversation as we pivot our plan accordingly, given physical distancing research guidelines due to COVID-19. During our first idea exchange, we explored the challenges you are facing in the context of the COVID-19 pandemic and the ways MIRA can best support you and your research during this time. Various themes emerged, one of which was exploring capacity for remote research. And today we will use a co-design approach to further explore options and opportunities around remote research. Our format today is a bit different than our last idea exchange. We have included speakers who will highlight specific ways in which they have adapted to our new normal. They will speak first, and then we will have time for a group discussion. If you have not already switched your view in Zoom to speaker view, we encourage you to do so. On your Zoom screen in the top right-hand corner, you should see an icon. If the wording under the icon says Gallery View, click on the icon once, and this should change to speaker view. We ask that everyone mute themselves during the presentations to eliminate any background noise or feedback. I would also like to alert you to the chat icon at the bottom of the Zoom screen. If a question or comment occurs to you during the presentation portion of the seminar, we ask that you please type the question or comment in the chat box, and we will review these during the second half of the idea exchange. Please note that this meeting is being recorded. Our first speaker will be Robert Call, President and CEO of Cloud DX Incorporated, an FDA-licensed Health Canada and ISO-certified medical device manufacturer and software developer based in Brooklyn, New York, and Waterloo, Ontario. Following Robert, we will hear from Dr. Dawn Bodish, professor in the Department of Pathology and Molecular Medicine at McMaster University, and Dr. Michael Wilson, associate professor in Health Research Methods, Evidence and Impact at McMaster University. Following the presentations, MIRA's scientific director, Dr. Parminder Raina, will facilitate the discussion. During the discussion portion of the webinar, you may unmute yourself to comment or ask questions at any time, or type a question into the chat box. We want this to be an interactive session, and we're anxious to hear your concerns and your ideas for how MIRA can provide support and assistance to you as you explore the tools and resources that will help you to transition your non-COVID related research to remote research opportunities. I'll now turn the time over to our first presenter, Robert Call.
Thank you so much. Really great to be invited to participate in MIRA today. Thank you so much for inviting us. Just a quick overview. Cloud DX is as you heard, both Canadian and US approved and certified creator of medical devices and software. And our real focus is remote patient monitoring and connecting subjects and patients outside of the 4 walls of a clinical environment with a clinical team or a research team. And so, since the advent of coronavirus back in February, March, everything has changed for us like it has for the whole rest of the world. During those the spikes of COVID, as we've seen them come and go, hospitals get overwhelmed, ICU units fill up. There's a strong impetus or strong push to both protect patients and providers, keep them safe and separate so they don't mingle, and to get people out of the hospital as quickly as possible. We've really embarked on a number of huge projects around virtual care with that in mind, some of them very much so with McMaster. So we've really seen our business kind of explode. We've ramped up to manage over 2,000 patients since March. And one of the most important projects we've taken on has been to work with both the Population Health Research Institute and Hamilton Health Sciences on a project called PVC-RAM, which has just finished gathering data, and PVC-RAM enrolled just under 1,000 patients across Canada in post-surgical monitoring using Cloud DX technology. So the idea was Patients were sent home as early as possible from the hospital with a full suite of gear that they could use in the home to both monitor their vital signs, answer survey questions, and as well interact with clinicians by two-way video and by text messaging. Nurses would follow those patients every single day and make sure that they were healing properly and they weren't getting into trouble. If vital sign metrics and or survey answers or just symptoms that the patient was experiencing indicated that they were having complications, they could be viewed remotely by video using a camera to take pictures of wounds and so on, very quickly triaged, and then the surgeon can make a decision, do we need that patient back in the hospital right away, yes or no? Anecdotally, a number of interventions were critical in improving those patients' outcomes and potentially even saving their lives. Once COVID passes us by and once we've all learned to cope and we're in the post-COVID world, we're very much focused both on that kind of post-surgical intervention, but also on chronic care management. We have a number of large projects across North America that we're working with entire provinces in some cases on chronic care management, specifically for conditions like COPD, CHF, hypertension, diabetes, and so on. We've been able to show clinically in studies that have been done at Markham Stouffville Hospital, with Women's College Hospital, for example, we can dramatically reduce the number of exacerbations that happen based on COPD patients using our system, and also reduce the number of ED visits that we're seeing. So what are we actually talking about here? So what CloudDX offers is a complete platform that goes all the way from literally the patient's skin all the way through a clinical dashboard to electronic medical record data collection. Patients work with an app on a tablet computer that we send to their home. In almost every case, we send a tablet with our kit. And then there's devices that go with that that gather blood pressure, pulse oxygen, body temperature, body weight, and so on. Some of those devices are actually made by CloudDX. So these are proprietary devices we invented and created ourselves, including a wrist cuff-based blood pressure monitor called PulseWave. And PulseWave is great because patients really like the wrist cuff aspect of PulseWave. It's also one of the most accurate blood pressure monitors on the market, the only one that we know of that's been validated in a cath lab against an interarterial catheter in a published third-party study that was done in New Brunswick. There's a dashboard, a clinical secure web portal, which allows clinicians and researchers to monitor patients and all the input and export of data back and forth from the patient's tablet to the system. That includes answers to surveys, wound care photos, transmission of documents back and forth, text message chatting, two-way video, and so on. So the clinical dashboard is what allows you to both track patients and gather all this data into a database. The system is set up for therapy. It's set up for actual care of patients, not just research. So there are smart software tools that exist that actually scan that data that's being gathered and looking for patterns, looking for changes. Perhaps blood pressure is increasing. In the COVID world, pulse oxygen might be decreasing, or there might be issues with breathing rate, or answers to surveys might indicate a change of symptoms. All of these trigger automatic notifications to both the patient's family, and the care team. So that's, again, a way to manage large populations of patients with actually a relatively small team of people and very efficient workflows. And then finally, all this data can be exported in various formats to electronic medical record systems and other databases. The system has been widely deployed. Parts of our system have been in commercial use in Canada since 2012, and we provide chronic care management remote patient monitoring services to the province of Alberta, the Yukon Territory, hospitals across Ontario, and across Canada as well, as you'll see in just a minute. In various different academic studies that have been done with our system, we've achieved 100% patient satisfaction and recommendation scores. And the last time we did a survey of clinicians, we achieved an 82% net promoter score from clinicians on how easy our system is to use, which, if you know how that works, is a very, very high mark. Now, the other thing that's great about CloudDX is that in addition to supplying this already approved, already fully licensed service, we also have a deep innovation bench or deep innovation pipeline. We are, for example, about to release a new version of our wrist cuff called PulseWave 2. Now, this device is actually being created in Canada with $1.8 million in funding from the next gen supercluster. What's unique about PulseWave 2 is that it's the only blood pressure cuff in Canada that measures breathing rate or respiration rate, in addition to systolic and diastolic blood pressure. And, excuse me, I'm gonna sneeze. Oh my goodness, excuse me. Blood pressure and heart rate. PulseWave 2 is coming to market in 2021. Behind that, we have something called Vitality. The Vitality is a continuous vital sign monitor. It's an extremely advanced wearable. Vitality is designed to gather ECG signals, PPG signals, so photoplethysmography or blood oxygen signals, and then also accelerometer and gyroscope signals. With all that input data, we can then export and determine continuous non-invasive blood pressure, heart rate, respiration rate, core body temperature, and blood oxygen continuously for up to 72 hours. We've been testing this platform since 2018 with the Population Health Research Institute at McMaster. The first paper has already been published on the ability of the platform to continuously accurately measure blood pressure on a patient wearing it for hours and hours at a time. So that paper's already been published in JIMER. This is a fantastic platform. We have an SDK that allows us to create apps around the data that's coming in. And we're working with a brand new grant from National Research Council, Innovation Solutions Canada, to reduce the cost of this hardware to a very, very low level, which I'll describe in just a minute. And then, if that's not enough, the third platform that we're very excited about is a platform called our cough analysis platform. This is software that came out of a giant project we were honored to be part of called the Tricorder X Prize competition. It was a global competition to create a working Star Trek medical tricorder. That's a whole story. You can Google if you want to. It's a great story. Bottom line is this software was invented for that tricorder. If anybody's ever watched Star Trek, it works a little bit like that. It's a smartphone app. It picks up the sound of a cough. It sends that sound to the cloud, and we analyze that sound to identify respiratory diseases. This is currently being tested in a large-scale clinical trial in Africa for tuberculosis in Mozambique. That whole project is being funded as a research project by the University of California in San Diego and the Roddenberry Foundation. Roddenberry was the creator of Star Trek. As you can see, we're gathering an enormous amount of data with this platform. And one of the things that we've been able to prove is that in amongst this data, we can determine in many cases whether a person has taken medication or not. So this is a data analysis product. It's not a special software app or anything. What this really is a whole set of machine learning algorithms that analyze this voluminous data, sphygmograms, PPG signals, accelerometer signals, et cetera, and determines a statistical likelihood that a patient has ingested a certain medication. We're very excited about that. It's a whole series of patents we own around that technology. And then the last thing we're going to just mention here today is we're working with Sheridan College and Microsoft on a way to experience all this data in 3D augmented reality using the Microsoft HoloLens headset. If anybody's ever seen that or tried that, it's amazing. Straight out of science fiction. Imagine Minority Report, holograms you can move around with your hands that react to your voice. Very cool. We just received a $100,000 grant from OCE VIP to take that closer to commercialization. So these are the type of products that we can share with researchers, and we can work together on analyzing use cases, analyzing outcomes, building cases for commercialization in various verticals using technologies created here in Canada. So we're happy to share this deck, by the way, with everybody. And the last thing I'm going to talk about before I move on is just some of the projects we're currently working with these technologies. So far this year, we're working with Vital Air Canada, which is one of the largest oxygen companies in the country. It's actually Air Liquide, the largest oxygen provider in the world. We're using our oximeter technology to help improve the at-home oxygen care for patients remotely, reducing the amount of person-to-person contact patients are experiencing when they're on oxygen using our remote technology. I mentioned the next-gen grant that we got for producing the new PulseWave 2 device. It's well in hand. We're also participating in a $1.4 million project sponsored by the Digital Technology Supercluster. This is a social network project called Stronger Together, where that Stronger Together application married to our remote technology is also being used in a perioperative model, helping patients before orthopedic surgery to get ready for their surgery and then monitoring their recovery. We're very excited about that project. I've already spoke about PVC RAM, which was the post-op project with Hamilton Health Sciences and Population Health Research. And then I believe I mentioned also that we're working with the province of Alberta for chronic care management. And then finally, the last layer here, the Tricorder X Prize competition, that's the AccuScreen cough analysis project in Mozambique, is ongoing. We have a project in Calgary with the University of Calgary. We're working with the largest air ambulance service in Western Canada to adapt our mobile technology, our wearable, for use in air ambulance triage situations. That's a terrific project. We've already done a pilot study. It's really, really a strong study. We're working with a project in Winnipeg on a machine learning project around predicting the likelihood of a myocardial infarction in patients using our technology. And then we have a really great project upcoming that's just recently been funded by CIHR for a 20,000 patient study of perioperative patients with population health research and again with Hamilton Health Sciences. And then last but not least, I mentioned earlier, Innovation Solutions Canada low-cost sensor grant is a project to reduce the overall hardware cost of our wearable, making it more accessible both for researchers and also, frankly, for clinicians. The more, the less expensive we can make that technology, the hardware technology, the much more widely it can be deployed. So that's our story. And I guess, I'm not sure if we're taking questions now or we'll do that later. But thank you.
We'll do that at the end. Thank you, Robert. That was really interesting. So we're going to have Dr. Dawn Bodish next. Dawn, do you want to share your screen and take it away?
Okay, hi. Thanks so much for the invitation. Thank you everyone for coming during challenging times. So I wanted to start off with a picture of my group in better times when we could all stand less than 2 meters apart from each other. And just as an introduction for those of you who I don't know, I'm an immunologist who studies infectious disease and respiratory infections. My lab does a combination of basic science research. We use mouse models, we use human samples, we use in silico approaches, and we also do a little bit of translational work. So my basic research program in aging is understanding factors, immunological factors that are associated with longevity. So the woman in the white dress there is sort of famous in immunology circles because she lived to be 115 and donated her body to science when she died. And she's what's called a supercentenarian, and many immunological studies were done with her donation. And so she and people like her have some unusual features. So they are very likely to have survived an influenza epidemic when they were young, and they're unlikely to die of pneumonia when they're older, which is something that kills many older adults. They have lower levels of inflammation than one would expect from somebody their age, and they seem to have unique properties of their gut microbiome. So my lab studies those three basic questions about longevity. We study the interaction between infectious disease and longevity and health. We look at how age-associated inflammation influences the immune trajectory. And then we also study the gut and airway microbiomes and understand how this predisposes us or protects us against infection. So that's just a little bit of background about me. And then I got sort of interested in COVID research because COVID or SARS-CoV-2 is a virus that breaks all the rules. So in general, whenever there's a new infection in the population, you see something like what you see on the left-hand side here, where young people and old people become ill. Young people because they have no prior immune experience, and in fact, that means they have nothing to draw upon. And then older people because they have this combination of the remodeling of the aging immune system called immunosenescence, and they also have comorbidities. Now, this is data from Iceland very early in the epidemic before we were really doing the social distancing measures. They were the only country that was routinely swabbing. And so at June, when this snapshot was taken, everyone on the island had been swabbed about 3 times. And so they're the only people who had a really good sense of what this virus looks like, who it likes to infect. And interestingly, there's an inverted curve. And so when these data came out, all of a sudden, people all over the world were saying, oh my God, I need an immunologist who understands aging. Because far from being susceptible, being immunologically naive seems to protect people from these infections. And despite the fact that older adults do die more frequently, it does look like to some degree immunosenescence prevents establishment of infection, and only when it's established does it become threatening. So I show you these data because they really were, from immunologists, absolutely tantalizing. You cannot resist a virus that so clearly wants to break all the rules. And as a consequence, we were able in early March to get some funding to do a few studies on SARS-CoV-2. So one of the studies that we're running right now are things, a local seroprevalence study to understand infection rates and immune longevity in people who've been infected locally. And we're doing this with researchers at Sinai. We're studying features of the airway microbiome that facilitate transmission risk and may explain some of these aging differences. We're also doing a number of immunological studies with local clinicians because there's a lot of questions about which drugs or health conditions may be protective or may ultimately cause people to become more susceptible. And again, the immunology of this virus is really fascinating, and it looks like people who have asymptomatic or mildly symptomatic infections have very different immune responses than people who have fulminant symptoms. We're also interested in, and unfortunately it's becoming increasingly apparent, that there's long-term immune dysfunction that occurs in people who've survived SARS-CoV-2. And currently we're putting together a study looking at long-term care grants. So in a way, I think this question about remote research is a little bit disingenuous for me because we are very much working in the lab, but under very modified conditions. So some of the challenges that we've been facing are the fact that every person on the planet who wants to do research that uses the same tools or reagents that are required for provincial testing or any other application, we just can't get supplies right now. So for example, every time we need to get some nasal swabs, we have to start a detective process to go and find. And in fact, last week we were told that one of our suppliers was not going to be making any of the nasal swabs we use in our studies because they were going to change their manufacturing process to do entirely things that were required for the provincial testing. So this is of course fair, but slightly inconvenient if you're trying to do research in this field. Other things that are challenging for us are just how do you get samples safely from place A to place B during a pandemic? How do you keep the staff who need to collect them safe? How do you keep the transportation safe? How do you keep the people who receive them safe? And that's been a challenge for sure. And I think the biggest challenge, and what I'm eternally grateful for, is that in a pandemic like this, there's no time to hire new people and retrain them. Things have to happen now. And so I've pictured here three of the key, not the only people in my lab, but three of the key people in my lab who've essentially totally pivoted and been redeployed to doing these covert research studies. So I'm blessed to have a really competent postdoc who's taken on a lot of the human immunology, a research coordinator, Jessica, and a research technician, Braden, who basically had to learn, implement, and validate a bunch of the tests we've done in record time and get them going. So this is, I think, a challenge for anyone who's sort of pivoting in this field. There's a lot of work to be done, and there's not a lot of people who are trained to do it. I know I follow Twitter very carefully, and everyone's trying to get people with these same skill sets. So although this speaks really well for their employment, it means, you know, getting these people up and running and keeping them and retaining them is obviously a challenge. The other adaptations we've had to make to doing a lot of our work is we need to do shift work. You know, we can't all be in the lab. So just having physical space to spread out and do the work in has been a challenge. And because we work with research participants, we've had to commandeer some space to be able to have them come in safely and some cleaning protocols and some greeting protocols about getting them in. And that obviously has been, takes time. And so it slows down the research process. I'd also say, you know, I know that from anyone outside the COVID field looking in, it looks like money is raining down from the heavens to do COVID research. But a lot of that money has been a challenge to receive because it's very applied and directed. So there's some, you know, very clear and questions that funding agencies want answered, and that doesn't really apply to every sort of research. And so certainly diverting money to get some of the pilot data, to do some of the validation studies was something that was a real challenge. And we were very fortunate to get a reasonably small chunk of money from one of our funders very early on, which allowed us to set the things up and really set up the lab to do more immunological studies as that was going on. And then of course there's the challenge, you know, everyone in an academic lab has a project. They are already doing research. And so now what we're effectively doing is running 2 independent research programs. One, all the stuff we did prior to COVID-19, and the second with all the COVID-19 work. So I'd say it's been tremendously stressful, and a lot of sleep has been lost from the team as everyone's trying to take on these dual roles. And keeping the original research running, writing the grants, doing the funding has obviously been a huge challenge. So and we definitely always have to sort of plan for, strategize, because there may be, you know, if one of the team gets sick, then who else can pick up that work and do that work? If, you know, God forbid we have a COVID exposure or something like that, we have to have a lot of planning around how we can mitigate those challenges. And then we also have to deal with the fact that everyone has lots of stuff going on in their personal lives, and it's just challenging. It's a challenging time to be working a 60-hour week for many, many weeks in a row. So one of our strategies is, as we're doing our hands-on research, we try to generate large data sets that, should there have to be a shutdown or should somebody have to self-isolate for 2 weeks, then they can take that data set and analyze it at home, so we don't really have a break in the research program. But of course that is challenging and not always possible. So this is my story about how we are pivoting and doing COVID research in a difficult time. And the take-home message here is that, although in some ways I think my lab and my team finds it very helpful to be supporting the fight against this pandemic, on the other hand, it's been very challenging for everyone. And I feel compelled to acknowledge the incredible sacrifices they've made in their personal life to be able to do this research. So thank you. That's all I have to say.
Thank you, Dawn, for sharing what's going on in your lab. Lots of really exciting research. And finally, we're going to hear from Michael. If you want to share your screen.
So hi, everyone. So I'm Mike Wilson. I work at the McMaster Health Forum. I'm the assistant director and do a variety of things, including running a rapid response program for policymakers and convening stakeholder dialogues and citizen panels. The forum as a group is focused on supporting evidence-informed policymaking, both here domestically in Ontario and in Canada, as well as working with partners around the world to do that work. I'm also an associate professor in the Department of Health Evidence and Impact. So my work, much like the forum, is very much focused on evidence-informed policymaking with a big focus on synthesis. So I'm going to talk a little bit today about how our work shifted in response to COVID and some of the things we've had to do differently in that context. So in my world, talking about evidence-informed policy, I'm talking about being systematic and transparent in supporting the use of the best available data and research evidence, but then placing that alongside citizens' values and preferences, as well as stakeholder insights across the policy cycle. So how governments set agendas, how policy is developed, and then how policy is implemented. So doing this really requires ensuring we help policymakers and others get timely access to synthesized research evidence, and the emphasis on time. So I run the rapid response program at the forum, where we use policy analysis, so analyses of benefits, harms, costs, adaptations, and views and experiences with different policy options. Systems analysis, so how systems run and how can they be changed, and then political analyses, so the impact of kind of politics on using research evidence and the policy cycle. So that's kind of my world. But then there's also the other piece around supporting evidence-informed policymaking is ensuring there's opportunities for exchanging ideas. So things like the panels that I mentioned to identify citizens' values and preferences that should underpin what we're doing. Lots of focus in the country and in many countries around what we call patient-oriented research, as I'm sure most of you know, and the central role that citizens and patients play in that. But then also stakeholder dialogues to generate action to address pressing issues, or we convene people to deliberate off the record about pressing health system issues. So the challenge is that those two things ended up being very hard and challenging to do during COVID, and we had to shift what we do in order to kind of meet the different demands and needs as when the COVID-19 pandemic emerged. So I'll just touch on that a little bit. So as we all know, the exogenous shock of COVID-19 in our world, that meant having to be even more rapid in responding to urgent policy challenges. So we thought we were already pretty fast in doing syntheses of research evidence in weeks or months, but we had to change to doing this within hours some days, literally just dropping everything we had to do, bringing together teams of 9 to 10 people, and putting together a synthesis for the government in Ontario and for the Public Health Agency within hours. We also had to rethink whether and how we use stakeholder engagement. So no one really wants to be on a full day video call with the same group of people. So having to think through whether and how we can do that differently when it's really best done in person. And then also thinking through what I think and many think is an unprecedented surge in interest in and demand for evidence synthesis. So it's meant, the good thing is that it's meant there's a lot of evidence syntheses that were being produced around the world, but it was being done initially in a way that initially wasn't very coordinated, with varying quality, and often with, it was duplicative. So people were doing the same, working on the same topic at the same time. So it's not a very efficient use of resources to have 4 groups produce the same systematic review or rapid review on masks. They could have been deployed much differently and produced 4 different syntheses that could have supported governments around the world. So we took this as an opportunity to be able to adapt evidence synthesis approaches and how to consider how to make that synthesis kind of more resilient and robust in the future. So as one of my colleagues recently put, we're trying to move from a high noise to signal ratio where there's lots of stuff being produced about kind of many different things, so it wasn't matching up, to a high signal to noise ratio. So we have a clear signal that we want to respond to and are very precise in the syntheses that are being produced and coordinated among many groups. So how did we change? So for the first one, I can't take credit for it. This was colleagues from both the forum and from the Ottawa Hospital Research Institute who created COVID-END, which is the COVID Evidence Network to Support Decision Making. So it's a time-limited network of groups from around the world. Most of the main research evidence synthesis groups are working within it to create this ecosystem around to collaboratively advance evidence synthesis. So for example, through that group, they created a guide to COVID-19 resources. So anything from sources for guidelines to living reviews to sources for COVID relevant systematic reviews, rapid reviews, protocols, titles that have been registered, to country databases that document country-based experiences as well. Creating a living hub of knowledge hubs. So any groups in the world doing this work, trying to put them in one spot so people can know where to go and engage who's doing work in this area. Evidence packagings, so tips and tools for that, and then decision support model, which I'll touch on in a second. So the group's now kind of out of that initial kind of what my colleague called the sprint phase into more of a kind of a long view of focusing on building an inventory of best evidence syntheses and horizon scanning and living reviews. What we know is that policymakers want, in situations where they don't have much time, quick access to the highest quality, most relevant evidence syntheses. So those need to be available at their fingertips. So that's what the group's working on right now. But then we also want living reviews that can help us identify where there are already reviews on a topic and prioritize new ones, so that groups who are working on this in that living hub of hubs can then focus their efforts on filling those gaps. What I've mostly been involved with over the last 6 months is responding in hours or days to urgent COVID-related questions through rapid evidence profiles with my team at the forum. So we've harnessed that guide to COVID-19 resource that's available through the COVID-END website. We've engaged a team of faculty, staff, and students at the Health Forum and from the Health Policy PhD program, and a handful of undergraduate students And we work very quickly to first refine the question, come up with an organizing framework to present to the requester to say, hey, here's a list of all the things you're probably going to have to consider in making a decision about testing. And then fan out and find every single evidence document that we can possibly find quickly to derive declarative titles, and then also scan other experiences of other countries to give them a sense of how other systems are grappling with this. So we initially were doing that in 3 to 4 hours. We're now mostly doing it in 3 days. It's not quite as urgent, but it's still kind of a stretch. And we're currently working right now on our 22nd rapid evidence profile since April. So there's been a high demand for these kind of things. And it's really been enabled by this real-time collaboration that we use through MS Teams. And the other thing is that our group, it runs RISE, which is the Rapid Improvement Support and Exchange in Ontario, which is the technical support for implementing an Ontario health team. So we had to pivot from that. Ontario health teams were put on hold, and we collaborated with the evidence synthesis table in the province, which I and a colleague sit on, to really collaborate very closely with the government to try and figure out what these topics are that they need evidence to. And then the last piece is just changing to virtual citizen and stakeholder deliberation. So we're still working through this. I'm currently preparing to convene a series of panels across the country and a national stakeholder dialogue about how do we enhance the use of technology in long-term care settings. So that's underway right now. We're going to split it up over 2 days, use MS Teams. We've piloted it once before, and it seems to work very well. So I'm very hopeful for that working out. So lessons learned, I'll be brief. The first is just being willing to innovate, evaluate, and adjust as you go. We wouldn't have been able to do this if we weren't able to just kind of be willing to drop everything else and then learn how to adjust our existing processes and then continually tweaking along the way. And then collaboration and coordination is essential. So that was the impetus for the COVID-N network, so the international team to try and enhance coordination to make the most of all the groups that are doing evidence synthesis. And then more locally on our team, trying to engage teams, including students, to advance our objectives. So trying to bring in our PhD students to bring existing and newly acquired and in-depth expertise and analytical frameworks that they're using as part of our studies. Some of them also bring international expertise. One has run a rapid response unit in Chile. Another brings extensive expertise from China. So we've brought them in, and also engaging a group of really great undergraduate students as part of the team to be able to do all this very quickly. So that's it from me, and I'm happy to take questions.
Thank you so much to Don, Michael, and Robert. Just wonderful contributions. And the question we want you to consider is, which tools or resources would help you to execute your non-pandemic related research in the next 12 months during and in the post-pandemic era? I'm going to give it over to Parminder to take over the discussion.
Thanks, Jazine, and thanks to all the speakers. And I just wanted to add a bit of a context within which we asked 3 individuals to talk about this whole issue. It is, obviously, we were looking at physical assessments and clinical data, many research projects, whether in the COVID related studies or non-COVID related studies. One has to start thinking about how do we go about collecting those data. I can tell you in relation to the Canadian Longitudinal Study on Aging, any physical assessments that we were doing, we had to stop. Not only to protect our staff, but it was also important to thinking about our participants who are older. And that sort of led to our exploration of what kind of remote technologies that we might be able to use to collect, if not everything we do, but majority of the physical assessment, vital assessments that are needed to continue to move forward and continue to do the program of research we have. So we've been having conversation with Robert and Cloud DX, and we wanted to showcase that there are these opportunities out there. They might or might not meet the needs of every researcher on this Zoom call today, but there's opportunity to have a dialogue with someone like Cloud DX and talk about what else they can do, work with you for example, tailor some of the technologies that they might be able to integrate, because they have, in many ways, if I think of it, they have a plug and play platform. And as there are devices that can be used, they will consider integrating them. I spoke to them last week and talked about, can we do spirometry data? And they've been thinking about that, how they can do that remotely with certain level of guidance through a video chat or something like that. So that was one piece. And second, we asked Dawn to ask, because talk about how she has managed lab research, which many of the labs have practically shut down. And she sort of eloquently positioned herself that how she pivoted to some of the COVID-related research. And I will ask a question, Dawn, to you in a bit, that you pivoting to COVID-related research, how did that allow you to continue to do your non-COVID research that started before pandemic? Did that help? Did that facilitate that aspect of research? So in laboratory setting, how do you become flexible and take advantage of the opportunity and the challenges that are facing us in order to keep our research enterprises going forward? And then third speaker was Michael, and we wanted to, from a social sciences perspective or population perspective, how do you continue to collect data? And one of the pieces that I was really interested in hearing from Michael was around the engagement with citizen panels, because there are methodological challenges that come into play when you don't have that face-to-face interaction, and how do they get around that? So in that context, these were the three speakers. There are probably many more, and perhaps if a group is interested, we might bring other perspectives to the table to discuss this, but this was to get the dialogue going. Jazine, you had a slide on, and what I will do here for a few minutes is to stop and let the group ask some questions to the three speakers if they have any specific, because that will automatically lead into the discussion that we want to have. So it's your forum, you ask questions, you have a dialogue, we will record information and synthesize and try to develop some tools and guides that might help you design your research as you think about moving your research agenda forward. I think there are people on this panel, rightly so, say that this research has changed forever. And this is not just next 6 to 8 months that we have to worry about. Research is going to be done in a very different way in the next years, 2 to 3 to 5 or 6 years. So this is our opportunity as a group of researchers to be at the cutting edge of using novel ways to collect data, interpret data, analyze data, and present data. And that's the purpose of this discussion today. So who has a question from our attendees to the three speakers? Imran, you might have to unmute yourself.
Thanks, everybody. It's great to join this discussion. And thanks, Parminder, for allowing me to ask the first question. So I wanted to ask my first question to Robert. I'm a cough researcher, and I've been doing cough research for the last 7 or 8 years. I'm from England. Part of my research is developing subjective and objective measures of cough. And I have some experience with developing cough algorithms to be able to detect cough sounds from speech and sneezing and laughing and other types of sounds. And one of the challenges that we face in that space is to do with data privacy. Because when you're recording people's sounds, often you are recording their conversations at the same time. So in what way have you been or are developing or have developed algorithms which doesn't require anybody to actually listen into people's conversations, and algorithms which are actually automatic rather than semi-automatic? I can't hear you.
That's a great question. So let me describe a little bit about exactly how we're validating the current cough analysis technology and the use case it's being used to address. We are working with a group of clinics in Mozambique, in Maputo. They're tuberculosis clinics primarily, but they're primary healthcare clinics, so they see a lot of tuberculosis patients. The challenges in the developing world around tuberculosis, and particularly in sub-Saharan Africa, are that it's endemic and it's expensive to diagnose, relatively speaking, to those healthcare systems. And there's a large stigma attached to it. Nobody wants to be identified as a patient who has tuberculosis. You can lose your job, you can be shunned by your family, you can be evicted from where you live. It's very, very challenging. So there's actually a resistance to being tested in the first place. It's very hard to get time off work to go and take a tuberculosis test. If you know you've been exposed, it can be life-changing. It can be very, very detrimental. So there's two sides to the studies that we're doing. One is an efficacy, obviously sensitivity, specificity. Can we identify tuberculosis versus other respiratory ailments at a high level of accuracy? But the second is the social engineering aspect of it, which is a little bit touching on what you're saying. So the current data acquisition phase involves patients in the clinic themselves. So these are patients who've come to the clinic. Every patient who comes to the clinic, it's actually a series of clinics, a group of clinics around Maputo. Every patient who comes in who has a cough is asked to volunteer for the study. Every single one who has a cough. By the way, we also gathered a large sample of healthy patients who were faking a cough, who were just making coughing sounds, but have no illness as a control. So then the patient comes in, if they have a cough of any kind, they're asked to record the cough. And we're using two methods to record it. One is a smartphone app on an Android smartphone, a very inexpensive Android smartphone. There are phones in the developing world that you can buy that are $20 US, but that run full version of Android. So it's a lightweight, application on the Android phone, and we're using the microphone on the phone. But then we also have a prosumer audio rig with two directional microphones and a prosumer high bit rate digital analog converter and so on. So we're simultaneously getting a very high quality sound, and then we're comparing the two to make sure that if we can identify tuberculosis in a high quality sample, what is the sampling, what is the accuracy in a low quality sample? The whole purpose of this at the end of the day is to validate the low quality signal from the portable phone. The application talks the patient in Portuguese through the process of gathering the sample. So they literally are listening to the phone. It tells them when to cough and to cough it several times, and then do it in several different cough trains over and over again to collect the full sample. In widespread use, the vision here is that if you have been exposed to tuberculosis or you feel you might be exposed, this app could be made available for free, paid for by the government. It could be literally included on the phone when you bought it. It could be like there as a government-sponsored app. Completely anonymous, and because it doesn't have to be your phone, it can be anybody's phone. It just gives you a random number to identify you, and then it records your cough, analyzes it, gives a likelihood of the person requiring further testing. So we're not trying to diagnose tuberculosis this way at the moment. What we're doing is we're just increasing the likelihood the person who might be exposed will go in for a more definitive test, and making those tests more efficient because there'll be less false positives and false negatives. So it's designed to be used in a personal manner on a personal phone that obviously you control, or in a way that is as anonymized as possible to protect the privacy of the patient in a way that's very, very sort of front of mind in this study, because that knowledge of a patient even undergoing this test can be dangerous. And so we're very focused on that with our partners, if that helps answer the question.
Great, thanks, Robert, because we want to move the conversation going forward. There was a question from Mara.
Thank you, Parminder. Hi, Robert. So I'm actually just forwarding to you directly the question that Parminder started with. So I'm involved in PVC RAM and in Vision too, and I'm saying that just to say that, of course, I value the technologies that you're using as instrument for risk prediction, for outcome assessment, etc. So as an intervention to test and study, but how do you see CloudDX and your technology and technology under development or developed in terms of facilitating to conduct research in the specific like a setting with like all the restrictions, and specifically all people here are doing research with older people. So thinking of technology, the interaction between technology and older people, and thinking also that many of us are interested in assessing measures like physical performance, cognitive performance. Where are you with your technologies here? Where do you see yourself?
Well, so CloudDX at its core is a data analytics company. We only invent our own medical devices to get data at a high quality level that we can't get from any other place. You know, we've invented the wrist cuff that not only gathers, not only measures blood pressure, measures respiration rate, but really what it's doing is it's gathering a multi-thousand data point radial artery sphygmogram, which we derive enormous amounts of fascinating data from. You can't get that in any other way. It's completely unique. The next closest device that does that is made by a company called SphygmoCore. It's a $20,000 box that an operator uses a tonometer to gather data with. So this is light years ahead of that. So for us, it's about that data layered on top of other data, simultaneously gathered. So inside that wrist cuff is also an accelerometer and gyroscope. So we're getting movement data, position data. Our wearable's the same way. It has multiple accelerometers and gyroscopes in it. So we're not only getting the core vital sign information, but we're gathering positional data, and potentially we have patents on the idea of adding GPS chips and cellular modems so we can gather this information any place on Earth. So one thing we offer is unique data that you can't get anywhere else at a reasonable cost. So that's the first thing. When it comes to usability, you mentioned interacting of old persons and technology. This is a real super strength of CloudDX. We've designed our technology from scratch to be as easy to use as possible for any age group. And we have study after study that has proven, published studies that have proven, our technology is universally accepted by people in the 60 to 100-year-old age group. The oldest person currently using our technology started using it when he was 97, has been using it for 3 consecutive years, uses it every single day, to 101, and he loves it. So we have a lot of evidence to prove that we have a really good data gathering and compliance model that helps us to make sure that we're getting all the data we need, whether that's in an academic study or for our own purposes of product improvement or marketing. So I guess there's really just 2 parts to the answer to your question. One is because we control every aspect of the device and the gathering of the data, we have all the raw data. We can export raw data, SE2 files and waveforms and that kind of thing. So it's great to collaborate with folks who are building data analytics models, machine learning models, algorithms. We do quite a bit of that work with some of our partners. And then on the other side, we have a system that has been designed from scratch to be widely deployed across the world, in fact, but in this case, mostly in North America right now, and to be extremely easy to use, both from the point of view of the subject or the patient, call them a subject in a research study, and also for the clinicians. We have an easy to use dashboard, so just gathering data and making sure your subjects are healthy. That, one of the conundrums when you're working with older people who have comorbidities is, what if in the course of your research, you discover this person is sicker than they thought? What is your obligation to take action? Well, we have a whole system designed exactly for that purpose, and so on. So we're excited to be able to offer these tools. I hope that helps answer the question.
Thanks, Robert. I think in the interest of time, I'm going to move forward. Dawn, I had a question. How do you manage your non-COVID research at this point in time, since you are taking on lots of COVID projects? Because majority of the people who might be around the call here today are not just focused on COVID research. We have to start thinking about how do we allow our other research to start moving forward in a modified fashion or some other fashion. And the same question I will put to Michael. Michael, your citizen dialogues that you are doing, how that has methodologically changed for you, what do you think of data you're getting through virtual interaction versus face-to-face you did? Are they comparable? How do you evaluate? How do you develop new methodology around that? So I'll ask Dawn first to address that.
I mean, one of the things we've been fortunate to do is because our research isn't that far off. You know, we study how the immune system deals with respiratory infections in general. So we're able to co-enroll people. So for example, our seroprevalence study, we can use some of the same specimens to fulfill most, if not all, of the research questions in one of our ongoing studies. So that's been a convenient way to be able to bring people in and co-enroll them in multiple studies. And then people are very, very keen to do that, especially in this cold and flu season. So that's been a huge advantage. And the university is technically open now, and there's no movement to, as long as we can keep the workplaces safe, to shut down the university. So we're doing a lot of shift work and a lot of trying to space people out so more people can work on multiple projects at the same time. So I would say that, you know, participant, you know, face-to-face research with people is tough, but a lot of the other questions that we have in the basic scientists, animal models, et cetera, things like that, they can still move forward. And I think the challenge really is training. I find that is going to be one of the biggest challenges coming up. It's really hard to bring new people in, and in our field, you know, the training process of learning how to do these things requires many, many hours, weeks, months, and you have to be near another human to do that. So I think the recruitment and training procedure is going to be the biggest challenge in the next year or so. And honestly, just also like keeping the lab workers happy and healthy. And, you know, I have so much sympathy for people who've joined the lab this September, new master's student or postdoc, who've moved, they don't have any friends here. And normally when you'd come to a research group, you know, when we would welcome you, we would have dinners and there would be things to do and we would get together and you'd meet a whole new group of friends. And now I find that coming to work is not as much fun as it used to be because we can't actually spend any time together. So I would say that is a challenge, keeping everyone's mental health and building those connections. And when work is not as fun as it normally is another big challenge.
Michael?
Yeah, thanks, Parminder. I think it's a really good question about the panels. So we are moving to a virtual format for now. I think, you know, my sense is we're going to lose some richness from doing that. It's just not going to be the same as having people in the room. From my perspective as a facilitator, it's harder to read even individuals' body language, to know when and how to kind of call on perhaps quieter participants to see if they would like to share. And particularly when we're dealing with topics that might be more personal or sensitive in nature, that might be, you know, I'm not sure. Some people are more than likely to be less willing to share that in an online format. And this is just kind of, these are hypotheses right now, I'm not sure. So my sense is that we're going to do some kind of, I guess, exit interviews to connect with a small number of people after we do some of these virtual panels and find out from them, like a one-on-one phone call or whatever it may be, just to get their thoughts on how they thought it went. We've done that before, previously with panels, when we were going through a redevelopment phase with it. So I imagine we'll do it now, and it's another big redevelopment phase of it, just to see what people thought, what the challenges were, and how we might change it. So in terms of the changes, what we're doing, we used to do this over a full day. So like 9 to 3:30, we'd have people there, we would have lunch, and, you know, really going to foster a group atmosphere. Now it's going to be probably 2.5 hours online on MS Teams. We're going to, and to account for the time lost, pre-record some information, background information for them. So, I mean, I think those would be the big things lost. And then the other piece that may be a challenge is getting some participants. We always aim for getting a diverse group of people in. So if that means wanting to pull in people from rural areas or those who may not be as accustomed to using online meeting platforms, then we may not be able to get the diversity we once had around the table.
Michael, related to that, and this probably relates to many people who are doing research, and I'm sort of connecting dots between what you're doing and what some aspects of Robert's technology. Obviously, it has resource implication. It might be possible, some aspects of technology like that, that allows two-way conversation. You can send a package to people for 2 days, 3 days, where they have a technology which is easy to use, and you can have a communication back and forth to collect data from groups of people who might not normally have access to technology or have resources to access technology. So there might be other novel ways to start thinking about outside the box as to how do we continue to do research using platforms that were probably not designed to do that type of work, but allows opportunity to look at new methods and evaluations. And that's why I was asking that question, because you are doing this. There might be opportunity, and there might be opportunity to even attract resources to repeat some panels, dialogues you did face-to-face, and repeat same set of questions on a same group of people using this technology. Do you get different answers? Maybe context has changed, and there's always that issue. But I think my concern, and I think there was a question Brenda asked of Robert as well, you are able to evaluate your technology because you had the opportunity to take people into the clinic and compare it against gold standard. Right now, we can't do that because we can't bring people in to compare something to the gold standard. So we have to come up with alternative ways of evaluating a particular methodology, because research at the end of the day has to have confidence in the methods we use in order to interpret the data. And I think these are some of the conversation we wanted to have today. How do we sort of develop ecosystem, dialogue, discussion as to how we collect data in new ways, and how does that compare? Maybe it's way better than what we used to do traditionally, but we have to generate a quantitative evidence to say it does work and works well. And I think the comment that Dawn made, and I think that's an important message for all of us, how do you sort of pivot to COVID-19 research that allows you to carry out your own research that was there prior to COVID-19? Because thinking outside the box and marrying those two also is an opportunity, not only from getting access to participants and bringing people to data collection sites, but also from a resource point of view. Right now, non-COVID research dollars have dried up. We are not seeing much of it coming from many sources, and it probably is going to be the reality in coming years. And I think those are the two messages I took out from your conversation here. Any other questions and comments and dialogues from other people on the panel? Do you see what conversation we are having? We develop some tools that help people to think about how to move research in these circumstances forward, whether it be COVID or non-COVID research, what kind of dialogue and interaction and collaborations you need. I think Dawn mentioned that collaboration is the key. It's actually now, it requires more collaboration than less, which we already work in that framework here at McMaster and specifically in MIRA. But there is an additional thinking that has to happen, which is going outside the boundaries that we normally work within, non-academic even. How do we sort of do research that we are doing? Was there a question, Vincenza, you have comment, question?
Not really a comment, really, in that I don't believe we have any more sort of non-COVID research. I completely understand that, Dawn, your research has to do with, immunology and all of that. But now I see things that are now stamped with COVID on them. So you will see how that affects, whether it's in the collecting of the data or how people's immunology will you know, develop over time or something like that, having sort of grown up, you know, I'm not using the correct words, having sort of been established within a COVID context. I guess I'm not seeing anymore that we have non-COVID research, and that's, maybe I'm playing with words, but I think it has changed the way we do things on a very fundamental level, including, you know, at the bench and those kinds of things.
Yes, thanks, Vincenza. There's a question, something like a follow-up to Parminder's question, and that is, are there any specific software features for interacting with patients, clients, participants that you or all of you really, really miss from the available mainstream solutions, something that is too niche for Zoom or Microsoft Teams? That was a question from Dobromir. As researchers, do we miss certain features in the technologies we are using that we would like to have, we don't have, and we can look at developing those, working with people, engineers, to add those features to the type of research we want to do? Okay, as you think about that, I want to come back to the question we asked. So, which tools or resources would help you to execute your non-pandemic related research? As I said earlier on, and others have said already, we are probably not going to get out of pandemic related research, even if the vaccine appears in a year's time. We will still be contextualizing any research we do in the context of the pandemic. So are there tools or resources that would help you, that MIRA can help develop, that helps aids any type of this research that we want to do? This is a free-flowing conversation, and
I have
any
one
wild
very,
ideas are good. Don?
I have one very basic thing that would help. It would be amazing if my whole team could all work at the same time again, but we can't because we have to stay 2 meters apart. So we have to be at about 25 to 30% capacity. So actually physically having more lab space would be huge for me, because then we could all actually work at the same time. That would be helpful. I know it's a bit niche for the basic scientists, but
Right.
something that would be helpful.
Anyone else?
So I'm struggling a little bit, Parminder, because I feel like the nature of my work, I can so easily pivot in the way that we've had to, because a lot of my work is synthesis. So, you know, synthesizing documents, and then the other piece is the deliberative part. So that's probably the biggest challenge. I think it's at least partially solved with virtual meeting software, but there's not much else I can do until we're allowed to be inside together with a group of people again to be able to do those types of deliberations in a meaningful.
But there might be an opportunity here for us to see how public dialogues and public engagement is being done around the world, and what kind of methodological evaluation. If we can identify those tools, they might be helpful to researchers like yourself and other social scientists who are getting, who need to do that type of research, whether it is pandemic or non-pandemic. And would that be helpful to you? For Dawn, I will look for a building which has really big rooms. In fact, it is, this is not a flippant comment. We are actually having a conversation right now in Hamilton. Should there be a physical location with all the lab space built in a way that allows social sciences to population sciences to clinical sciences to lab sciences and happening in the same building? And perhaps the design of the building might be dictated by where we are in the pandemic world, so we don't run into this difficulty in the future. Where it will go, when it will happen, I don't know, but there is a dialogue happening right now. It is something people are thinking about. Not only in this, there's also an infectious disease hub being created, and that might happen as well. Any other comments and other types of tools or resources people need? I guess one of the question is, doing these types of seminars or ideas exchange, are they useful or are we wasting your time?
I guess, Parminder, I'll just say that, like, I think it raises some points, but sometimes I'm not going to just, right? Like, you have to think about your ideas a little bit, right? And reflect on this, as opposed, I know there's people that can think aloud in the moment and then write their ideas as they communicate them, like I am right now, can be a little bit messy, but I think we have to, like, there are some things I have to think about and come back to it, right? So one thing I find is if there were a few sessions that were based on this, that we built on what Dawn and our three speakers, thanks to all of them for sharing their stories, but I feel like you have to build as opposed to switching topics.
No, that's what we are asking. Where do we, that's a very good segue, Brenda, that where do we want to go with this? So what—
if you're building a building, that's very long-term, right? Like that's not—
That was just a comment response.
That's what I'm saying, Parminder, is actually, I like the idea that there's going to be a building, but like what can we do short-term? Like, and when I say short-term, I don't even really know what that means. Is that a year? Is that next month? Is that 6 months from now? I like the idea that there'll be a building that brings lots of people together, but that's like very, and it's great that that's being thought about. I just think, I'm thinking a little bit more short-term, that's all.
Absolutely right. And I think just to add to that, what we are thinking about is what MIRA can do now. MIRA can't build a building. MIRA can do what it can. And specifically, I would say over the next 6 to 12 months, what do we do? Because this is definitely with us, at least for that period of time, if not longer.
Like, I don't know, Dawn. I know that the Infectious Disease Institute, there's a lot of coordination there. And I think they're a good example for us at MIRA, that when I think about, if I'm going to just talk aloud right now and think about, the Ford assembly plant, right? And if you think about research being at different ends of the assembly, like how do these different components, like Dawn, has a very specific, then somebody else has to carry that forward. I don't think we can have our own, everybody has their own assembly plant, is what I'm saying. And I think that's how research currently functions. So I'm trying to think about
that might be if one thing emerges from this, that not every researcher, every investigator will have their laboratory for their own use. It might become a multifunctional space that is large, big enough to accommodate these challenges going forward. It might actually shift our whole enterprise of research on its head if people really think about, I would say the likelihood of another pandemic in the next 10 years is not that small. It's going to happen if we look at MERS and SARS and now this. Frequency is there with all the global travel and the climate change that is happening. So all of this enterprise has to be thought through from a scratch in a larger way. Shorter time, I guess we are looking for how do we get people back to doing research that they already were doing and is completely halted right now. Are there things, other than giving more money, which is always the easiest solution to everything, right now I can tell you from my own perspective, money has actually become a problem because you can't hire people. Dawn said, you can't find people. What do you do with their money? Deliverables are in 6 months, 8 months, and 12 months. And sometimes money is not the solution to all these issues. It's having those other resources and tools to be able to carry out. I don't know if there are other comments from other people around the Zoom. I would really be interested in knowing what can we do together.
Parminder, can I say a few comments?
Mm-hmm.
So, because I do a lot of clinical research, one of our challenges is being able to collect data from patients, both from a research perspective, but also from a clinical perspective. And there's two things which we use all the time as respiratory physicians. We every time somebody comes to clinic, we do an FEV1, we do spirometry, for example. Or we may do sputum analysis. Some may do. So I've been thinking about, what are the alternatives? So we either go down the route of giving everybody a mini spirometer and train them and just train them once, and you may not have brilliant quality the first, second, third blows. But if a patient is doing it every week at home and telling you what their numbers are, then the likelihood is that they'll get better at doing it. That's one option. The second option is to revert to a completely oscillometry device, which is just tidal breathing, and just develop a whole system of methodology which will tell you something about lung function and airway resistance, which is not the exact same as FEV1, but something. And then the other option is, if we can't do sputum, especially in the current climate, then what about things like breathomics and volatiles? And I'm actually in conversation with a company who may be interested in collecting breath sample and being able to validate it. And the third issue is, one of the things I'm finding from patients is that because they're not coming into hospital, it takes them an hour or 2 hours for an appointment. So they actually, some of them prefer shorter conversations on the telephone, but more frequent. So what you lose in the face-to-face, you gain in the frequency. So I'm finding is that you may lose in the face-to-face and seeing patients and that, but actually you may have the ability to ring them more often and keep a contact with them more often. And in that way,
Imran, let's talk about spirometry for
Yeah.
1 minute, which is an important tool, and people who are collecting data are really nervous, especially who are not in clinical setting, to collect breath data during pandemic, all of that. We were having conversation with the Roberts group and in other groups as well, because there are these devices that allow you to have a conversation both ways. We could send our device to people at home, and our data collectors in our data collection sites can actually guide them virtually how to do a lung function. That's all we do in the room when we are sitting right next to them. We just guide them how to do it. So there might be other ways to achieve the same thing. Second one, I would say, and I've learned this over several studies now, there is just this assumption that non-clinical setting data quality is not good. I think you can train people in a very well fashion. I give you an example. We did ultrasound for carotids in the CLSA. We had clinicians and ultrasound technologists doing it who are trained to do that. And we were able to get exactly the same and a better standardization with our own self-trained technicians in our data collection sites, right? I think there is a professionalism that protects some of this that we are the only one who can do. I think you can create certifications, you can train people. We did the same with DEXA, bone density. We don't have radiation technologists in many provinces because we don't need a radiation technology. You can develop protocols to improve the quality and training in many, many ways. And I think there's ways to do it. It's just now we are facing those ways and we can explore that we would normally not do.
I completely agree that there's a lot of, I don't know why, apprehension of getting patients to do things at home via virtually. It is completely, but there was always hesitation for the reasons you mentioned. My only other concern is I've noticed, because the older you get, they get less comfortable with technology. So whatever technology you use is going to be quite simple.
I think you heard Robert comment on that as well. They have done a lot of work, and we have spoken with others and some of the work we have done. I think there is a bit of an ageism that happens, that older people can't use technology. I think a lot of them can use technology. There might be few who don't. And they have more time available to learn it, and they do learn it. And pandemic has shown it again and again. The use of technology among older people actually has gone up substantially. So I think those hurdles are manageable. Question is, how do we develop our own tools and resources to support you going forward?
Parminder, can I jump in for a second?
Yes, please.
Yeah, so I think it's a great comment about how we shouldn't assume that older people can't use technology. However, I think we might need to ask a bit more of a targeted question with that. Is say, which types of older adults may not be well equipped or positioned to be able to use it? So the question comes from a project I'm working on around the use of technology in long-term care settings with AgeWell. And the what I've heard from several people is that it's really challenging in long-term care settings too. And someone, I think it was Isabel McKenzie, who's a seniors advocate in BC, said that they've recently done a survey of long-term care settings to find out how many residents would be comfortable or even willing to use some form of communication technology, and it was only 10% who said that they would actually be able or willing to use it. So I think it's just more the question then shifts to how can those technologies then be adapted that might make it easier to bump up another percentage of people to be able to use those types of technologies within long-term care. I think they might be the ones that are perhaps the hardest to reach with some.
Absolutely. I think the segmentation of the population becomes really critical, what you can do and what you can't. And I will add to that, in long-term care facilities, if there are people with complex health needs but are not older, will have the same challenge as the older people.
And dementia in particular.
Right? Yeah. Anyways, we are in the interest of time. I think one of the things we can do, and Jazine, you were recommending this, that we can, what do you want to say about Jazine in relation to how can we collect this information the way Brenda mentioned that people need to think about it? How do we capture that information from people after the fact? Jazine, you were suggesting something.
I think that what might be helpful is to put together a resource page on the MIRA website that just points to resources for remote research, so we can have some links to Robert's resources, for example, some things like the remote recruitment methods that we have at MIRA. There are also databases at McMaster for equipment that can be shared and infrastructure. And I think that if we did a kind of a one-stop shop there for McMaster researchers in aging, that might be helpful. I think putting it in the newsletter, it might get overlooked, but if we have a page on the website, I think that might be a good place to start. Also, I appreciate that everyone's getting the wheels turning and maybe doesn't have anything to say right now, but you can definitely reach out to us afterwards, send us your ideas, your questions, and we can make this a very iterative process. So, I mean, if you didn't say it here, you can still say it later. We're open to hearing about it.
Is there a possibility for this ideas exchange creating a little bit of a discussion board where people can throw their ideas and can have a real life dialogue with other people who might? Or is that going to be very difficult to do?
I think that's a question for Kara, because she would be setting that up.
Yeah.
And somebody would have to moderate it as well, right? So it needs.
I don't know if it really needs to be moderated or people can put their comments and then we summarize and synthesize and say, this is what we heard.
We could do something like that on Microsoft Teams. That would not require a lot of setup, for example.
Okay. PJ, do you want to wrap up in the next 2 to 3 minutes?
Yeah, just thanks for everybody for today. I'm coming live from Ireland and just helping with these sessions. I think today's session was useful and everybody's points were really valuable, and the speakers as well. I think the idea of a platform in which people can share over time might be useful as well. Either if it was, we have to figure out what that might be, but it might be an ideas board as well. And there's various kind of online platforms that we can explore, that if you have an idea to share it, even if it's just on a virtual post-it note. I think just from the discussions today, I think we're in the middle of the experience of understanding how our research is pivoting. So this is going to be an iterative process that's going to happen over time. So I think Brenda brought up the point that, you know, we have to look at this over time and live with it for a little bit, and people to come back with ideas. It's probably not going to happen over a couple of hours. So maybe if we can think of ways in which we can share ideas over time might be useful as well, and co-design over time.
Great. Is there anything else, Jazine, from your point of view? This, in a way, these whole ideas exchange is an experiment for us. And we will have to get eventual feedback from you whether this is a good use of your time, because what we found that in general, there was not much happening at the university and asking questions and saying what are the challenges and how do we sort of collectively overcome those challenges moving forward. Since then, I know Faculty of Health Sciences has had one of those discussions. And some of you who were not part of first conversation we actually did a survey of all the members of MIRA. We got quite a bit of response on different issues, and these topics that we are developing are based on what we heard from people through that survey. So we will continue to move forward unless we hear from you that this is not a good use of time and you're not getting anything valuable. I'm not sure yet whether we are generating anything valuable or we are just creating a research support group to say we are all in the same boat and we are helping and supporting each other in one way or another. But I guess we will know when we start seeing dwindling numbers coming to these ideas exchange that is no longer of interest to people. It seems like majority of the people on the chat box have said that they will like a page and some live interaction or resource page started on the MIRA website, and that could, and as Imran said, it could be a Kijiji for researchers. One idea that we have been looking at and MIRA's team is thinking about, I don't know how many of you heard an app called Window Swap. If you haven't, you should look at it. It is two people from Singapore developed because they were stuck in a house for a long time and they loved traveling. So they started asking their friends to take a picture of a view from their window, either looking out or looking inside their house. And it has become a phenomenon around the world in how people see their environment and how other people see that environment through their lens. And recently it has been picked up by a whole teaching group to teach students to do creative writing. So they ask students to take a window they like and write a story. Who's the person behind it? And we have been thinking about, and this sort of reminded me when Don said, training is going to be an interesting issue going forward. And we have been thinking about some sort of a research swap type of app where trainees and researchers actually interact with each other in a way that we don't see in real collaborative fashion, right? I might be thinking about an idea or talking about training my students from a very different perspective. If that was out there, how do we sort of get that in the hands of other people and other people's ideas? So it's a very rudimentary idea, but there is an idea that we are thinking about how do we sort of do this idea swap, which protects the proprietary nature of our ideas to some extent, but also allows us to train and generate new ideas to move forward. And so we are in that era. We are going to have to borrow these types of concepts from completely unrelated fields of research. And that's why we are trying to bring people from, in the future, bring somebody to come and talk, maybe not 3 people next time, we'll have 1 who has nothing to do with our research, but they might be the group of people who might give us ideas to use something what we want to do. Anthropologist, I just heard a story. He knew that he was not going to bring his graduate students into the classroom or into his lab to study birds that he studied. And he started going and created over the summer, taking pictures and created a whole library. And he's using that library virtually to train his students about whatever he trains them about the birds. And I think there will be opportunities to create something totally out of the box, which could become a niche for McMaster and McMaster researchers, new methodology, new technologies, new way of thinking. And I hope that's what will come out of this when we sort of think through these things, really requiring some unbelievable lateral thinking. That's what is needed. I'll stop with my sermon.
I think we should wrap it up there.
Yes, yes.
Definitely, I can look into discussion boards or doing some sort of a Reddit. And I really like your idea that we can generalize from completely different disciplines as well and maybe get some ideas that will help our researchers. So I want to thank Robert, Dawn, and Michael very much for your participation in our webinar. Researchers, if you have additional questions, please email us at mirainfo@mcmaster.ca and we can direct them to the speakers. Our next webinar will take place on November 11th at 3 p.m. Dr. James Gillette and Dr. Dee Mangan will be discussing polypharmacy and deprescribing, the paradox of prescription medicine for older adults. Thank you.